at this point, I would just like to very briefly sort of preview the agenda, and then ask Farzad to make some opening remarks. So thanks everyone for joining. And today, what we're going to do, again, Farzad will make some opening remarks. We're going to introduce the Forum Steering Committee, and we're going to talk about sort of our processes going forward to really launch the hard work of the Forum to develop sets of common approaches and candidate best practices. So we'll get started with that work today. We'll also talk about how we're going to get a couple of work groups initiated to do this work. And we'll talk about sort of the overall kind of timetable for our work in the coming months. And then we'll have a couple of presentations and discussion around some of the initial trust principles that we're going to be working on. So we'll get into the details. But at this point, I'd like to turn it over to Farzad for his opening remarks.
Thanks. I'll keep it brief. And the overall message is now it's time to do some work. I think this group has all the right people for us to be able to take what we believe as a result of years, really, of committee deliberations and recommendations. We set out what we believe are reasonable principles in the framework and hope that they will serve as the basis for common trust frameworks nationwide. But the work of this group of people who are implementers and doers in the field is to hammer it out at a more specific level in terms of what that's going to mean. And we've chosen, I think, wisely, two use cases here to start with, two principles to start with. The first should be a low-hanging fruit. Maybe it's building trust in the process, but come on, let's get this part done. What are the simple explanation of the privacy and security policies and practices, making that transparency principle live. The second is going to be a little more challenging, and yet this is one of the most important issues that we hear all the time, is how do you deal with the concept of meaningful choice, and how do we make that operational in practice. And here done it, hopefully coming up with best practices that could be either voluntarily adopted, certainly, but also could go into consideration for our Federal Advisory Committee. So without further ado, I turn over back to you all to get some of this important work underway.
Thank you, Farzad, so much. And if we could go to the next slide, please. As you know, we've been planning to create a steering committee for the Forum, and we went through a process to get all of you to vote on the steering committee. We had a lot of really wonderful people kind of raise their hand and volunteer. The steering committee is going to play a very important role to help us focus the work of the Forum, provide guidance and participate in various work groups that we get underway, help to facilitate consensus wherever possible on common approaches to health information exchange governance, as well as candidate best practices, and to review and refine the outcomes of the Forum, which will include writing up the common approaches to various health information exchange governance practices and building consensus on those best practices. So we're really excited to have an outstanding group of leaders with very different perspectives and experience who've been selected by all of you to serve on the steering committee. So we have Mark Chasen, David Kibbe, John Madison, Paul Uhrig, David Whitlinger, and Marianne Yeager, who will be the Forum Steering Committee. So we are getting underway to get the first meeting of the Steering Committee scheduled, in the next week or so. So that will be getting underway very shortly. Next slide, please. So the next agenda item is to discuss really the process for developing sets of common approaches and candidate best practices, again, the core of the work of this Forum. So in general, the approach will be to leverage ONC's recently released framework of principles for trusted health information exchange, including principles on organization, trust, business, and technical principles. The forum participants will participate in prioritizing the items from this framework in terms of which principles are most important for the group to address. Work groups are going to be created from the forum participants, and we'll encourage volunteers to work on each principle that is identified as a priority. A co-chair or a chair or co-chair will be selected to help lead that process of the work groups. And the steering committees will certainly be welcome but not obligated to participate in each of the work groups that are kicked off. The process is also going to include gathering information from the forum participants on their current practices related to those principles that are selected. And we're going to really try to make sure that the information gathering process is as streamlined as possible, because we certainly don't want to burden anyone with onerous information requests, and we want to be sure that information can inform the work of the work groups. So the work groups will convene to review and analyze the information that's gathered. They'll work on putting together a draft report to identify common approaches and candidate best practices for review and discussion with the full forum. The forum participants will then work to reach consensus on those common approaches and candidate best practices if possible. And if we have challenging issues where we can't completely reach consensus, then we'll, hopefully the report will reflect those different approaches and why those differences may be necessary and appropriate. Since this process, we haven't done this before, we haven't had a collaborative process for really tackling these types of HIE governance practices before, we really don't know yet how hard or how easy this may be to reach agreement on all these things. So, while this is sort of the vision and the plan for how we'd like to see this unfold, we're not exactly sure. It's sort of uncharted territory for all of us. Next slide, please, on the forum output. So this graphic just sort of shows how the output from the governance forum may be used in multiple ways depending on what comes out of it. So the idea is for the forum to distinguish between common approaches and best practices that entities and their participants could voluntarily adopt, and those that may need to be brought forward through ONC's federal advisory committees for consideration for nationwide implementation. So we just wanted to reinforce that there may be multiple ways that the outcome of the forum can be used to help accelerate progress. Next slide, please. So let's just take a few moments to sort of talk about how we will initiate the first work groups that I've mentioned. So you may recall that a few weeks ago we asked all of you to rank the trust principles from the framework of principles based on 3 criteria. Those criteria included, is the practice promising for common best practice approach? Is it significant for nationwide exchange? And how challenging is the issue to tackle? So the results of the prioritization exercise that we went through together ended up with, as far as I said earlier, 2 practices, 2 trust principles sort of bubbling to the top. One is privacy and security, and the other is meaningful choice regarding patient consent. So those have emerged as the first couple topics that the forum will work on. And in a moment I'll show you sort of the results of the survey to show you how we ended up there. But first I wanted to sort of talk through this proposed timeline for the initial work groups. So the plan is to get 2 work groups underway soon to work on these first couple of trust principles. So right now we would like to invite volunteers to participate in the first group, work group, which will be on privacy and security practices. And if you would please, let us know within about a week, preferably by the end of this week, if you are interested in participating in the privacy and security work group. We're really excited to sort of announce the chairperson for this work group, which is Cheryl Stevens. And in terms of the timetable, we will be launching the information gathering process here within the next week, and we'll be asking for information on how you all are handling privacy and security practices, so that work, again, that information can flow into the work of the initial work groups. And so for the privacy and security work group, the work will take place between June and September. And then we hope to get the second work group on meaningful choice for patient consent kicked off just shortly thereafter, so we can get a little experience underway with the first work group before we launch the second. And the work of the meaningful choice and patient consent work group will take place between July and October. And we'll be asking for volunteers for that work group in just the next few weeks. Next slide, please. So I wanted to just sort of share the results of the prioritization exercise and sort of discuss how we ended up with these first two trust principles at the top of our list. So this graph is really about the trust principle related to privacy and security practices. And we wanted to sort of show the scoring for each of the top three criteria, as I mentioned earlier. So this, the privacy and security principle really scored very high for the first criteria of promising for best practice approach, really kind of bubbling to the top here. It also scored very high for significant in contributing to nationwide exchange. And then finally, it's scored quite low in terms of most challenging, sort of indicating that it would be, potentially relatively easy to work on, which is important so that we can accomplish some early wins and build momentum for the future work of the forum. So there was one trust principle that scored higher than this one for significant for nationwide exchange, and that one related to personally identifiable information being consistently and accurately matched, so sort of the patient matching challenge. And the reason we didn't put that one on the agenda for the forum is because there is some important work underway on this principle currently, in particular by the New York eHealth Collaborative and EHR HIE Interoperability Work Group as part of their exemplar HIE governance grant. Next slide, please. So this is the trust principle related to meaningful choice for patient consent, and so this one was a little more challenging, so it kind of ranked higher as challenge, so we aren't shying away from a somewhat challenging issue. And it's been certainly seen as high for significant to nationwide exchange. Now, this one was sort of mixed on promising for a best practices approach compared with some of the other principles, but we really thought that patient consent is certainly consistently mentioned in many contexts as a priority and a challenge related to exchange. So we thought this would be a good second trust principle for this group to work on. Next slide, please. So after those two initial work groups on trust principles are underway, the plan is to go through another exercise to prioritize principles, and we would turn to the business principles category to come up with the next couple of topics to work on. So, so then what we'll do, again, we'll prioritize to identify the next business principle. We'll work to gather information on those priority business practices starting in the July timeframe, and that again will inform the work group's efforts. And the expected timeframe for this work is not 100% clear yet, but we sort of estimate that it will take place between August and November. So the hope is, the expectation is that the forum will have really 3 work groups between now and November, 2 on trust principles, privacy and security practices, and meaningful choice for patient consent, and then a 3rd on one of the business principles that's identified by the forum participants as a priority. Next slide, please. So the overall timeline for the forum, sort of incorporating the work group process, report outs, and consensus building efforts, is going to, take place between the next, our summer months and the early fall months. And we sort of expect that the results of the privacy and security work group should be reviewed and discussed with the forum in August initially, draft, and then finalized hopefully with consensus in the September timeframe. And then in terms of draft results of the meaningful choice work group, those will be reviewed in draft form with the forum in September and then finalized and hopefully with consent reached by the October timeframe. And then finally, draft results of the initial business practice principle would be reviewed with the forum in October and then finalized with consensus, if possible, in November. So that's sort of and in that point, I think the forum will sort of determine, can we tackle other principles, assess the progress and how far we've come, and then determine next steps. So the output really will be, a report from the forum with the results of the topics from each work group, including a summary of common approaches and candidate best practices. So this may be a very aggressive or ambitious timeline, but we think it's what we need to sort of strive for at this point. And certainly, I think all of you want this effort to be very, very productive. And so we need to, press ahead to try to contribute to accomplishing consensus around some of these practices so that we can contribute to widespread and successful nationwide health information exchange going forward. So we think this will add value and hopefully be a successful foundation for additional work. So we've kind of covered a lot of ground on process and kind of how the work is going to be organized going forward. So I'd like to see if we have any, pause now for any questions or comments on what we've talked about so far. And you can, of course, I think you all have the ability to talk if you unmute yourselves, or you can certainly raise your hand and we can call on you, or you can write in your questions as you go. So let's see. What do we have? So we have a question kind of in the written in. So one question is, are members of the work groups limited to the members of the forum, or can we bring in subject matter experts? I think that we certainly would welcome subject matter experts to contribute, to the effort. I think that would be an important way to get the work done. And then it looks like we have some people with their hands up, so I'm just sort of scanning here. Dave Minch, did you have a question?
No.
Okay. How about David Muntz? Did you have a question? I'm seeing some questions popping up, but maybe they're being addressed, and I'm just not seeing that. Anybody, any questions or comments? And I should ask that my ONC colleagues if there's any refinements they'd like to make to the process that I described.
Kate, I think that was a great presentation. I think it would be great to turn it over to folks to have a discussion on some of this.
Okay, thanks, Jody. All right, so we do have a couple of people we asked to come prepared to comment on sort of what they're doing in terms of these particular initial trust principles, so on privacy and security and meaningful choice. I'd like to first call on our colleagues from California. Dave Minch is going to lead us off, and I know we have Gloria Hitchcock from Rochester as well. So Dave and Cassie, would you like to take it from here?
Sure. I'll start off, and then I'll hand the control over to Cassie to talk a little bit about our demonstration projects. I want to start, go ahead and let's flip to the next slide, by talking a little bit about some of the history in California, specifically the California Privacy and Security Advisory Board, because we've been actually have been at this for some time. The Privacy and Security Advisory Board was initiated in 2007 by Arnold Schwarzenegger, and after about 5 years of work was disbanded in early 2012 by the new governor. And it's interesting to note that you consider the fact that California has got 36 million plus or minus people in it, and it's a big state, and it's very hard to come up with any given opinion that we can converge on throughout the state. The group really worked very hard at coming up with a single strategy for consent, and at the end of all of that ended up with more best practice recommendations. And I think some of this will be useful to this group, and we're certainly more than willing to contribute all of the information that we've compiled over the years of the California Privacy and Security Advisory Board. And the other thing that was created, which I think is also something that might be of use to the group, is kind of a format of patient rights, and specifically expectations that patients should have of providers when their data is being exchanged. Flip to the next slide. Some of the best practices, and I won't go through them all, I just wanted to put them up, and these are really the best practices in terms of an opt-in model or an informed choice model where the patient is actually given the choice. And these were some of the principles that we came up with that we felt were important and could lead to the best structure for actual policy. And again, I won't go through them all. It's interesting that, and one of the things that's in here that did have a lot of discussion is all information in. So when you do opt in,
Michael, how are you?
When you do opt in,
good. Are you able to talk?
An explanation of an expectation.
Oh, goodness.
That there would be essentially no restrictions.
Michael needs to go on mute.
Excuse me, Dave. This is Kate. If you're talking in the background, please mute yourself on your line. Thank you. Sorry, go ahead, Dave.
Sure. So it's and the reason we came up with this was primarily because of a recognition in today's information environment with the EHRs that it's very difficult to actually pick and choose information, especially sensitive data, which I'll talk about in a minute, because the sensitive data is buried in places and could, in fact, even be buried in locations that are not even searchable through simple text searches. So the idea was that at least for general medical information, if you agreed to opt in, you would be opting in with the full record. There's some interesting things, and I think this is also important. There were some ideas that there are some components of that we needed to avoid in policy. Certainly, policies that are frozen in time and can't move forward with technology would be some of those. And of course, conflicting with state or federal law. The thing that, again, we felt important is that a patient should be faced with one consent requirement when they are at the entry point, their highest level entry point, and not have to have multiple consents for various types of data. Next slide. So after the Privacy and Security Advisory Board, we formed a policy steering team under Cal-OHI. And just to give you an idea of the California legal landscape, there's a general constitutional guarantee of the expectation of privacy in California. There are many laws in California that actually govern and restrict the general gathering and exchange of information. Laws that say that information should only be gathered for a specific purpose, and it should be limited only to that purpose, and the information should not be exchanged because it was gathered for a particular purpose. And these are general laws, not healthcare specific. And then we do have many healthcare specific laws that focus on specific types of data, mental health data, and so forth, labs, believe it or not. And then, of course, we have many court decisions which would act to modify the behavior of clinicians with respect to the disclosures they make. Finally, and interestingly enough, we do have laws which require maintenance of appropriate security, and in some cases those are not as strong as HIPAA. Next slide. So one of the things we're actually presently involved in the policy steering team is really to look at consent specifically for information that would be considered sensitive. And in studying the laws and in studying the requirements for consent, interestingly enough, we came up with this bullet list. And again, I won't read them all. I'll just kind of put them up there for your enjoyment. All of these end up being variables that affect consent, either the actual requirement for consent or who can consent, what the form of the consent is, and so forth. And I do think it's interesting that each of these variables actually has, somewhere between maybe as few as 3 or 4 potential values, up to some of these variables have maybe a dozen or more values. So if you picture in your mind a matrix that has about 12 dimensions to it, and then each of those dimensions has anywhere from 3 or 4 to maybe over a dozen rows. You get the idea of the number of intersects that one would have to actually satisfy to give a complete picture of consent in California. Next slide. So where we've actually come to, and I'm going to just kind of leave the group with these 3 thoughts in California, is that we really need to be moving forward on 3 different areas at the same time. I think first is regulatory. One of the things that's interesting in California is that even if you do things that are appropriate and are done the right way, you still, in fact, can be penalized. There's a court case a couple of years ago that was called the Tarasoff decision, and actually it was visited by the California Supreme Court twice. And it was, in fact, a mental health worker had disclosed information to the authorities on a person who could potentially do harm, and they were sued because they didn't actually advise enough people, and the authorities didn't actually take any specific action to keep the event from happening. So even when somebody does the right thing, they can be sued in California, and that's something that we have to address, I think. The other part of it is simply harmonizing definitions and terms and trying to bring California law and HIPAA at least a little bit closer together, while preserving, I think, some of the things in California which are actually good privacy protection. The second thing is educational. I think we need to make the general public more aware of their rights and expectations of privacy. And the flip side of that, I think, is really trying to make people understand the benefits of data exchange. The third is the most important in my mind, which is improving the public trust. And we have to do that in such a way that people can look beyond the privacy concerns and the things that we see in the newspaper every day about 500 records that were lost here and 1,000 records that were disclosed there. If the public trust improves to the point that they at least are assured that we're doing the right things and we're doing the best we can from the respect of security, then I believe a lot of the concerns will be mitigated and this whole process will become a lot easier. With that, next slide, I'm going to turn it over to Cassie, and she's going to talk a little bit about the demonstration projects. You there, Cassie?
Yes, I'm here. Can everyone hear me?
Yeah, you're going to speak up a little bit. You're kind of weak.
Okay, yes. Can everyone hear me now?
That's better. Perfect.
Thanks, Dave. So I wanted to share, I'm hearing a lot of feedback. Is everyone else hearing that? I think it sounds better. Okay, so I wanted to share a little bit about our demonstration projects, give you kind of a brief update on what we're doing there. So we have 3 demonstration projects here in California, and what we are doing is we are testing consent, opt-in, and opt-out. The first one we have is the San Diego Regional Health Information Exchange, and this is part of one of ONC's Beacon Community programs. And it's a partnership of healthcare providers, clinics, hospitals, emergency medical services, and public health organizations. And they are actually testing a mixed model consent policy. They have multiple different facilities, as I mentioned, and some of them are testing opt-in and some are testing opt-out. So that will be interesting when we get the results, the final results back. We are currently in the process of evaluating the evaluation and test period. So that's our first demonstration project that's going on. The second one is Inland Empire, and Inland Empire Health Information Exchange is a collaboration of hospitals, medical centers, medical groups, clinics, IPAs, health plans. They also have public health and other healthcare providers. So they have more than 4.2 million residents in that area, so it actually covers a significant amount of ground. And they are testing an opt-out consent policy. And then the third one we have is the Santa Cruz Health Information Exchange, and they're one of the oldest and most advanced multi-stakeholder exchanges, definitely in California and possibly even in the country. They even extend to county detention centers, regional reference labs, imaging centers, and safety net clinics. So they cover a lot of ground also. And they are currently testing an opt-out consent policy with an emergency exception. And so I wanted to share with everyone some early findings from our initial assessments that we've done so far. So the trend that we're seeing is that when offered the choice, a large majority of patients elect to share their health information electronically. So they're willing to share even if it's being shared electronically. The second finding we have is both opt-in and opt-out are effective means of managing consent when implemented successfully as a part of a comprehensive privacy and security framework. So it needs to include education for both providers and for patients. So the success of a consent management policy does depend on numerous factors, including provider engagement, training and education of provider and office staff, patient demographics, and HIE governance. So we're in the process of continuing to collect data for the next several months, and then we will have a detailed analysis and some recommendations that will be included in a legislative report that will be released at the end of this year, and we'll have it posted on our website, and we'd be happy to share the results of those demonstration projects with everyone. So that's all I have, unless anyone has any questions.
All right, thanks, Cassie and Dave. This is Kate again. And does anybody have any questions for Dave or Cassie? And you can either, probably the easiest thing is to raise your hand, or you can type the question into the chat window, or you can just chime in if you wish.
Just as far as that, I guess as a general rule, I think we're going to get, the sooner we can get to the conflict, the better. So I guess the question would be, what are the areas where there's going to be disagreement or conflict in what you presented?
So this is Dave. This is Dave. When you talk about the areas of conflict, maybe I'm just missing where you're
controversy, disagreement.
I think probably a key part of the disagreements that we've seen in the work that we've done to date revolves around the granularity of consent, if consent's going to be, if you're going to have a consent or essentially an all-in type policy. And it's really probably a problem that as time goes on we'll have fewer problems with, because we'll have better EHRs and we'll have more granular information. However, I think at the end of the day, it is an issue that's going to have to continue to be front and center, because as you're aware, as you look at the medical chart, even a simple continuity of care document, you have information in that that can infer diagnoses, even though a diagnosis might not be present. And you have information that any given patient at any given point in time might consider sensitive. And I think it's really the sensitive data that is causing the biggest set of issues for us. And as we get into consent and talking about consent and the forms of consent, will continue to be one, because we have different rules governing it, and some very specific rules even at the federal level. So that's an area I think we're going to be having a lot of discussion.
And this is Cassie. There is a lot of controversy in California in terms of just interpretation of our laws, because many people here in California, our attorney here at Cal HIE kind of references it as an Easter egg hunt. There are so many different laws that govern the sharing of health information, sensitive information, that you have to literally search to try to find all of the laws, and then to be able to comply with all of them is almost impossible, and actually share the information even when it's needed specifically for treatment purposes. So that's where a lot of our conflicts come, because the federal law conflicts with many of our state laws. So we have plenty of conflict here in California.
This is Jody Daniel at ONC. Can you say more about conflicts of state and federal law, since usually the rules make it clear which one governs and does not preempt state law?
Sure, and Dave, maybe you could chime in a little bit more about this, since you've been involved in this with the policy steering team for a lot longer than I have. But we have several laws, I know, related to sensitive data that specifically California requires more privacy, where we cannot share. Dave, can you speak a little bit about that?
Yeah, it's probably not so much conflict as it is. It's probably not so much conflict as it is the force of the law. In California, we do have many laws which are much more restrictive on information sharing, and those, because of the way the federal state requirements work, because those laws are more restrictive, they actually take precedence over federal law. And that's where we run into a lot of issues. We don't so much have conflicts, although we do have some very interesting situations around 42 CFR Part 2. And the other complicating factor in California is the fact that our care models, and I think this is true throughout the country, I'm just obviously more familiar with California, but our care models are changing, and we're going to mixed environments where we have care teams, and the care teams are made up of medical physicians, mental health physicians, social services, pharmacists, and so forth. And consequently, we have mixed records, and that makes it more difficult to be able to distinguish. Does that help, Jody?
Kate, can the operator find the line that's making that noise and mute it?
Sure. I'm I'm sure he's working on it. Any other questions for Dave or Cassie?
So can you talk more about how and I know about California having some law, federal law, can you talk more about how that affected some of your thinking and best practices and how you see that affecting the exchange of information outside of California, how that played into the practices that you had, and what kind of discussions you had about that?
Sure. I think one of the things, and you know, we've actually looked at the DRSA pretty heavily, and one of the principles in there is principle of autonomy, and I believe that works very well as you start looking across states and look at California versus other states. Within California, we have to follow California law, so each organization has to make decisions, especially when data is being disclosed to states outside of California that may have different laws. So that's part of what our discussion has been around. I think the other part within California, and again I'll go back to some of the principles, the idea of all information in with no restrictions, is this recognition that in today's environment and with today's records, if we do have an informed consent process, or essentially a process where the patient actually gets to decide whether or not to share their records, they have to be allowed to make that decision and be informed that once they make that decision, the data will be shared and all of the data in the record will be shared. So if there is some sensitive data that's in the record that may be protected by various specific rules in either California law or California court decisions, that data is in by definition. And that's, our discussions have gone down that road, and I think, again, probably the most significant thing we need to work on in California is more from the other side of trying to come up with ways that we can really make sure that the patients have a high degree of confidence that we're doing the right thing and that we're protecting the data appropriately, so that we can have fewer conversations about what might be sensitive and what patients may or may not want to show to which physicians or which caregivers.
Hi, this is Claudia from ONC. We often hear the adage that California is like a nation itself. I think one of the things you offer is where there are multiple exchange activities going on across many different organizations. And it looks like one of your strategies try to come up with practices that widely adopted in resolving healthy issues. And I'm just, as this group itself launches on a similar effort, I'm wondering if you could share any either warnings or, hey, this worked kind of findings about, were there specific practices that your group came up with that, in fact, not through regulation but through voluntary adoption, have actually found their way getting implemented across the state? And what were the opportunities and challenges in trying to get folks to kind of identify best practices and really adopt them widely across the state?
Well, one of the things we're hoping, and Cassie alluded to the demonstration projects, we are going to be getting a lot of very good information out of those, and again, slightly different approaches for both doing informed consent up front and doing what essentially has been true pretty much across California to date, which is essentially a no consent or a kind of an opt-in, opt-out, methodology. We're doing that by default. We've recommended some best practices, but the demonstration projects are really our first attempt across California to come up with some observations and some best practices. And clearly we'll be happy to share those with this group as it proceeds. I don't think we have much in the way of findings to date to help. I can certainly tell you some pitfalls as the group starts evaluating things, and some difficult areas that we're going to run into simply because we did hit those walls several times with the PSAB, the Cal PSAB process. So as we proceed, we'll be trying to lend some wisdom in that area.
And this is Cassie. You also asked about exchange across state boundaries with other states, and we had, through the Western States Consortium, now the National Association for Trusted Exchange, we had a pilot with Oregon, and the baseline that we used for exchange between California and Oregon was the use case that we had was sharing information electronically for treatment purposes, from provider to provider for treatment purposes. And we really sat down and looked at, well, what would we do if we didn't have HIE? Well, we would fax it. So the information would still get from California to Oregon or vice versa. And so we really looked at, we didn't look at sensitive data and all those more complicated scenarios. We looked at the most basic exchange, and we followed HIPAA in terms of our exchange. So we were able to exchange from California to Oregon and vice versa for treatment purposes securely via direct. And so that was, we have a lot that we have learned. We have policies that we have established and that we have available that we can share. We're still working on getting them all up on our website, but we have that. We've learned from that experience, and then also we've taken what we've learned from the Western States Consortium and applied it to the California Association of Health Information Exchanges. In the bottom left-hand corner, you can see the little logo, and Dave Minch is is one of the co-chairs of that organization, and they're the ones that are actually working. Also, Dr. Madison from Kaiser, they're also involved in this group, and they're the ones that are working on kind of the baseline for trusted exchange in California. What are the minimum policy and technology standards going to be for electronic exchange in California for multiple HIEs to trust each other and exchange with each other? And Dave, you could maybe mention a little bit about that.
I think you did pretty well. It's work in progress, and this group is only about 10 weeks old, so we're still getting our operations together, but we do have a couple of work groups that have already been fired off, actually 3 now. And we should start getting results back from that within the next, I'm expecting within the next month and a half to 2 months.
This is Tia Tinney with Search. I'm not quite sure. If you're looking for information about exchanges that take place across state lines and what kinds of issues you run into when you're doing that, Search has 7 states that are planning to be up and running into production by hurricane season for the purpose, the use case of disaster preparedness. A couple things, and our exchanges have been going fine. We haven't ran into many problems, mostly because we're going off of state-sponsored HISPs. So when it comes to that third-party type of information exchange, that's something that we haven't really gotten into. But as far as our exchange, we use, our baseline and underpinning of our privacy and security is HIPAA, and then we use the NIST Level 3. Of course, not all the states have different policies, permitted purposes. But I guess maybe for our use case, and because we're doing point-to-point exchange, the patient consent is a given at that point, because if you have a patient that's relocating and that patient goes to a doctor and another state, then they say, I would like to have my information from, you know, the doctor in my home state. So I'm not quite sure if that's what you guys are looking for, or issues that come up in multi-state exchange, but that's some of the things that we're facing.
All right, why don't we go to Gloria Hitchcock from Rochester, Rio, and then we can continue the dialogue and questions after that. So Gloria, you want to talk about sort of how you guys are handling these issues?
Sure. So if you go to the next slide, please. So just a little background on Rochester and where we are. We cover 13 counties from Lake Ontario to the Pennsylvania border. We offer a couple of different services. We have a query portal called the Virtual Health Record, where we have about 2,800 users, 800 or more are physicians, and we have about 21 million results since we were instituted that are part of the Virtual Health Record. Consent, there's about 968,000 unique patients in our area, in our region, have consented already to at least one provider out of a population of about 1.3 million. There's a total of over 2 million total consents, so you can see that patients are signing up and signing consent for more than one provider. In New York State, the Department of Health privacy policy is a consent to view, so we can stage and gather the data, but patients sign a consent form for a HIPAA-covered entity for them to be able to actually view the data. Next slide, please. So the consent policy, patients have to provide written consent to allow anyone to view their VHR data. They can revoke their data at any time. It is a durable consent, so it is in force until the patients revoke them. About 97% of our patients do sign consent when their providers ask them to. And we do have a break the glass policy where we do audit those to make sure that it is a true emergency. And one of the things that we found is one of our AIDS clinic is with very complex disease patients really have the highest percentage of positive consent. They really see the value of having providers be able to see their entire medical record. Next slide, please. So not only can patients sign consent in their physician office, but as part of one of our HEAL grants through New York State Department of Health, we put up a patient portal, and that hangs off our consumer website. It was designed by one of our local partners. And here on this landing page, it explains all the different things that a patient, if they sign up, they get access to. So we'll just kind of step through some of the things that they have to do to actually sign up for a patient portal account. Next slide, please. So because we never really see the patient and we don't know who they are, we wanted to have some kind of identity proofing or IDP. We use Equifax, formerly known as Anacam. And so the patients go through a process that's very similar to set up online banking. So identity proofing really kind of asks, does this patient really exist, and do we know that that's the right patient? They could ask questions very similar to what's the range of your mortgage payment? Is this one of your past employers? What's your past address? In the back end process for this, because as they step through this, there's a back end process, and it checks to Equifax checks publicly available data, including their credit information. If they pass, it goes and looks at the master patient index and does a patient matching algorithm. If there's an exact match for just one patient, then the account is created. If we get back more than one option, if there's 2 Mary Smiths or if the information is too close for the algorithm to match with 100% certainty, they get a notification that they need to call the RIO and have the RIO's deployment team link that account manually, so we make sure that we're matching the right patient and their data. Next slide, please. So after registering, they also have to set how they want to be able to get this 2-factor authentication for when they log in the second time. And they get this passcode that they have to actually enter. So they choose whether they want to get this by email, through an SMS text, or if they want a phone call. They can register a specific IP address for up to 6 months, so it will hold that information. So next slide, please. So then, after they actually get in, some of the things that they can do once they're in and once they have an account is they can request an audit of any of the providers that have actually looked at their data in the RIO. They can also scan and attach an advance directive. So there's a lot of value for the RIO for this. Next slide, please. The next thing they can do is they can actually sign up. Our local kiosks are connected to the RIO, so they can sign up if they go to the kiosk and create an account on the kiosk. They can just click this box and actually connect their data so that providers see if every time they go to get groceries they have their blood pressure checked, or if they download their glucose meter, that information is in the virtual health record. Some of the things that have been a little concerning for providers here, providers are always concerned about patient-provided data. They are a little bit more comfortable because we have shown them that the kiosks are routinely calibrated. And the asynchronous communication, we made sure that we put notes all over, making sure that patients realize that if they have some very out-of-range results that they need to call, that they can't just load it to the kiosk. Next slide, please. So then setting consent on the portal, we thought this was going to be a really helpful thing. So we set it up so that patients can search for the providers that are actually using the RIO services. They can search by name, they can search by address, practice type. Once they found their provider, they can set their consent for an entire care zone for a patient-centered medical home or a health home. If care managers from a health plan are users, they can set that consent online. So they can do a lot of this automatically. Next slide. But you can see that over the 2 years this has been in effect, we've not had people beating a path to our door. And some of it is, even though patients can create an account, they may find that their physician is part of a larger health system and their specific doctor is not participating. We've not really done any marketing at all of the online option to be able to set consent. So these people are folks that have actually found this on their own. Next slide, please. But you can see from our consent dashboard that we really do have a lot of consents. But the paper-based consent that's done in the provider's office for access to that specific consumer or patient's trusted health provider really continues to be the bulk of the consents to view data in the virtual health record. Next slide. So the slow adoption, really there's not a lot of perceived value to go through that whole identity proofing and two-factor authentication process because we've not been able to really roll out access to clinical data for a patient. Our original vision was that we would have a PHR gateway so that a patient would be able to choose any PHR, any personal health record that they wanted, be able to get HIE regional data sent right to that PHR of their choice. Some of the barriers have included some of the CLIA regulation interpretation. There's a variation in our community's hospital data release practices. Physicians have been a little resistant to sign up to yet another way for their patients to get data, because with meaningful use, a lot of physicians are already rolling out individual practice portals that include a lot of transactional functionality. So patients are actually able to schedule or reschedule appointments, get prescription refills, as well as looking at their data. Next slide. So the consent to view is still stronger, and positive consents are much more positive when patients are asked to sign that by their own trusted provider. And I'm available for any questions.
Thank you, Gloria. This is Kate. Any questions? Any questions for Gloria? Comments? Okay. We have a couple others who I think were sort of prepared to talk a little bit about how they're handling these things. I wanted to see, Jim Youngkin, do you want to share some of what you're doing on consent and privacy security at Keystone HIE?
Yeah, sure. I'd be glad to. I think I did get a couple of slides added on here to the end of Gloria if you want to put them up. Yeah, so go ahead and forward down two sets here. Just to give people background on the Keystone Health Information Exchange, we have 38 healthcare companies. Please just forward probably 5 times is a build slide so you can see that there's hospitals, practices, nursing homes, and home health participating here. So getting consent right has been a big challenge for us. And if you go to the next slide, it shows what some of our stats are. So these are the hospitals that are connected and publishing. If you look under patient information, there are, now these are February stats. I think we're closer to 700,000 patient authorizations signed. Those are not unique patients. Patients in our model will sign an authorization at each facility that they receive care from. So, and a facility being defined really as an organization. So if you sign an authorization at Geisinger Health System, you only have to sign one authorization there for their information to be viewable through the Health Information Exchange. But then if you go to another healthcare organization like a community hospital or outside physician, you would have to sign another authorization there. Wanted to point out a couple of other stats on here as it relates to this discussion. We have total, it says My Key Care, that's our patient portal that is connected to the Health Information Exchange. Those are the number of patients who have signed up to use the portal that's connected to the HIE for viewing information. And usage, I think, is also important in the bottom right-hand corner. Because even though we're up to a total of 3,000 users who have IDs and passwords, we're finding that our current usage is probably between 150 and 200 users using the system per month. And I think that's largely to do with some of the challenges around consent. If you could go ahead and forward. Pennsylvania last year in July passed Act 121, which creates an authority to oversee the statewide health information exchange. But in it, there was a provision for identifying an opt-out for information being shared in Pennsylvania. However, it did not address any of the especially protected information, which in Pennsylvania we've identified as the HIV psychotherapy notes and drug and alcohol treatment. And so that's something as a state that they will be looking at hopefully this summer and making some recommendations, but really don't feel that we'll have good buy-in at a state level on this opt-out policy until somebody can address the specifics around the specially protected. HIE has been operational since 2007, and really based its consent model on something that Geisinger had already had in place for its outside physicians to be able to access information that Geisinger has in the EPIC record. And they felt in order to be able to do that, we had to address the issues of the specially protected information, and therefore created what was called a universal authorization form, and with the intent being that a patient signs this one time per organization. So in this case, being developed at Geisinger, they would specifically initial next to specially protected information. So they'd have to initial the HIV, the psychotherapy, and the drug alcohol treatment, each separately, or the form was considered to be invalid by our, and each form was reviewed by our medical records staff. So you'd have your registration people collecting the forms and setting the indicators that the form was collected, but then on the back end, HIM is reviewing everything, and they're resetting the flags if in fact they found the forms to be inadequate. So this was the model that was adopted by HIE. So now each organization is responsible for collecting its own authorizations. And so one more slide. I wanted to show you that we'd also brought in some additional patient control. Can you forward the slide, please? And we have an application called My Key Care, which is the patient portal, and it allows providers to control what information is shared with their patients. They can indicate that the lab results, maybe all lab results are shareable with patients, but maybe other types of tests wouldn't be. So we give them the ability to control that. It's eventually a tool that we're going to allow patients to sign authorizations electronically through this tool, but for our purposes, getting that kind of back feed that goes back to each of the organizations so that they can update their electronic registration systems with the fact that the patient has given their authorization through this external process really hasn't been worked out. So in summary, we're struggling a lot with this. We feel that it's a conservative approach, and that at least in our state and many others that have this issue with specially protected information, that unless something is done at a higher level, we feel that we need to have the ability to either block specially protected information from being viewed, which if it's just a matter of identifying ICD-9 codes or other kind of codified information in the record, it's probably something that we could easily do. The problem that we have, and as many others do, is that the information that may be buried in the text of a note is unclear whether or not a text document contains specially protected information. And of course, therefore, we have reverted back to the safe approach to say, well, let's just get authorizations for everybody and not share anything unless we have that authorization in place. So, if we could come up with a way to either limit the scope of the of how much digging we have to do in order to be able to block sensitive information. If we could all agree that looking at problem lists or codes or something like that is all you need to do, that I think that would be helpful. But as long as providers feel that we're responsible for the details down in the notes, it's going to take something like natural language processing logic to identify if those kind of documents contain specially protected information.
Thank you, Jim. This is Kate. Any questions or comments related to what Jim discussed? Okay, thank you so much, Jim. Mm-hmm. And I think we had a couple others. So Cheryl Stevens, did you want to talk a little bit about what you're seeing in Minnesota and what you're hearing, maybe happening elsewhere with regard to privacy and security and consent? Are you there, Cheryl? I think you're muted, Cheryl, if you can unmute yourself. Okay, maybe we lost Cheryl. So, it seems there are a number of themes, at least that I'm hearing, and maybe others have additional thoughts. But one is sort of this issue of granularity. Are you sort of all in with consent, or can you sort of pick some information or pick some providers that you share with? And then there's certainly complex issues related to the sensitive or protected information. And then certainly the issues that were discussed earlier about different state rules and federal rules and how do we reconcile those things. We did have a couple of comments that came in. Maybe there would be a reaction to this. So one comment was sort of about, a lot of what we've been talking about is provider-centric, provider organization-centric. Is it possible to talk about, putting the patient or consumer in control of their own information beyond consent, but even directing sort of a consumer-directed or mediated exchange? Any thoughts on how that might fit with these topics?
So this is Cheryl Stevens. I can talk a little bit about Minnesota, or you can go on with your discussion, whichever you prefer, Kate.
Why don't you go ahead, Cheryl?
Okay, I'm sorry. Unbeknownst to me, I had to unmute on the computer as well. Anyway, I'm from Minnesota. We have very strict privacy and security requirements in the state, but I think considering what we've all talked about so far this phone call, I'm just going to go over what the state of Minnesota has put in place in regards to health information exchange and what we call our record locator service law. It requires anybody who's going to be participating in HIE offer the ability to opt out to every one of their patients on their release of information or their patient consent or their patient authorization forms, whichever terminology you may be using in your organization. Specifically, there is a paragraph that has to be inserted into that form that informs the patient that they can either opt out, or if they don't opt out, their information will be available for exchange. So interestingly enough, within the state of Minnesota and within the participating organizations that we have on board now, we're running at about 0.07% opting out. As far as the mechanics of how that works, every one of the participating organizations then forwards those opt-out, those forms that have the opt-out completed directly to us, the HIO in the state of Minnesota, so that we have a singular place where we enter that information into the Record Locator Service Consent Management Module. And now that there are more organizations coming on board as HIOs or health data intermediaries in Minnesota, there will be a single consent management tool that will be, we've received the contract to maintain that here in the state of Minnesota, so that all opt-outs will come to us. And the purpose of that is so that patients do not have to try and remember where they opted out, or whether they opted in at a different office, or if they changed their mind, because those types of information, those sheets of paper come back to us, and we then inform the original organization where they may have opted out that they've changed their mind. And of course we go into the system and remove that flag indicating that they've opted out. It does cause some complexity, and many of our organizations were afraid of what it was going to do to their workflow and the amount of paperwork required. But as I said, the fact that there's only 0.07% of people actually following through on the opt-out paperwork, the workflow or the impact on the workload has been very minimal. I think that's a lot of that can be attributed to the training that the registration and admitting people go through as they come on board to the HIO, so that people, they can explain to people that their information will still not be shared without consent, but it can be loaded and available for exchange during an emergency if they were unable to give their consent. So to summarize, Minnesota has kind of a hybrid situation. Everybody's ADT feeds from participating organizations get uploaded into the Record Locator Service, but none of the patient data can be released unless there's the signed patient consent. And that signed patient consent must give them the ability to opt out of sharing any information. So it's a tiered but very patient-centric model. Does that make sense? I think I'll stop there so that everybody who has questions or wants to talk in closing can do that. Thanks for your time.
Thank you, Cheryl. So anybody else, I mean, what are your thoughts? How is what we've been talking about so far, the various different perspectives, you know, similar or different? What thoughts does anyone have?
Can you hear me?
Yes.
Hi, it's David McCauley. I think the last point about a tiered model is really important to keep in mind, that when we talk about opt-in and opt-out, we tend to sometimes oversimplify it down to a single tier, when in fact you could have behaviors that differ at the different tiers. So you are essentially opting out of the record locator, but you have to opt in to data sharing. And I think models like that are going to be more feasible in the long run than sort of a single notion of opt-in of everything or opt-out of everything. I really like that tiered model.
That makes sense. Other thoughts?
Yeah, this is Jim. I wanted to comment on David's thought there, which I agree with in terms of getting to the functionality that ultimately we want to be able to provide. But I think that we also have to be careful that these solutions are not so complex that it confuses patients even more. And you know, just the idea of having an opt-out and an opt-in, I'm concerned can be overwhelming to some patients.
This is David. I agree. I think that the other missing component was mentioned by the previous speaker, or maybe actually I think it was by Kate in the commentary in between, which is putting the patient in charge and thinking of this as consent to go get my data rather than providers having to think in terms of consent to release the data. So if the patient is sitting there with the provider and the provider says, I can tell that there's data available out there, would you let me go get it? Will you give me permission to go get it? And the patient says, sure, you need it. That's pretty simple and easy to understand, and I think this tiered models can support that kind of an approach. It doesn't work for every setting, obviously. You've got emergency settings and the like, so you still have to deal with all the edge cases. But the common case is pretty straightforward.
Any other questions or comments? Any other thoughts? Well, we're just about out of time. I think it was a really really good discussion of these initial trust principles and some of the different approaches and challenges and ideas. So I think we should probably bring the session to a close. And in terms of next steps, again, please let us know, ideally by the end of this week, if you'd like to be a part of the privacy and security work group, and we'll be pulling that group together, and we will also be in touch with you to gather some information on your approaches and on some, so we can identify commonalities and sticking points and try to better understand those. So our next meeting of this group, the National HIE Governance Forum, is late in June on Thursday, June 27th at noon Eastern Time. So I guess that we'll need